Good morning, everybody. We're going to keep on rolling here. My name's Will Robinson. I'm from the University of Virginia. I'm going to, I guess, moderate the next two sessions, two kind of shorter sessions, one on visceral artery disease, and then following this on thoracic outlet and upper extremity disease. So, well, that's loud. I'll start off here and talk a little bit about the open and endovascular management of visceral artery occlusive disease. So what we'll do here, basically for a quick outline, we'll go through some of the etiology indications for treatment. We'll talk a little bit about endo-revascularization, then talk about open revascularization options, look at a little bit of comparative data between endo and open, of which there is not a lot, you might not be surprised to learn, and the rest of it's cut off, so I'm not quite sure what we're going to do at the very end of this. So if you look at mesenteric ischemia, I mean, there's all sorts of etiologies, but by and large, 90 to 95% of it will be atherosclerosis, the top one. But there are a whole host of disorders and pathology that can actually end up causing mesenteric ischemia. So chronic mesenteric ischemia as a clinical diagnosis is rare, but as you probably have learned, atherosclerosis and stenosis of vessels is actually not rare at all. So if you look at autopsy specimens, a reasonable percentage of patients will actually be found to have a visceral artery occlusive disease. And as you do more and more lower extremity work, you'll find that 27% of these patients actually have asymptomatic visceral artery disease. So this was an angiogram I did on somebody, I must have been planning it for a lower extremity endo-revascularization, and you see this huge meandering mesenteric artery, which was indicative of celiac artery and SMA occlusive disease. So you see a lot of asymptomatic disease as well. So the basic tenets of the indications and treatments are as follows. If you have a patient with chronic mesenteric ischemia, the bottom line is, unless you're sort of in a palliative situation, revascularization is necessary for them to live, ultimately. Because the natural history of true chronic mesenteric ischemia is ultimately bowel infarction and death. And so it doesn't mean that you operate on all or revascularize all patients with this, but that really kind of has to be your starting point. And the goals of revascularization are to reduce the pain, obviously, of eating for the patient, to prevent infarction of the bowel, and then let them regain their weight and nutrition, which ultimately malnutrition would prove to be fatal. So on the other hand, though, there's virtually no role for prophylactic revascularization when you see severe disease, if it's clinically asymptomatic. Now, one possible exception, to that might be three-vessel critical disease, so celiac, SMA, and IMA disease, in sort of a questionable situation, where it's hard to know if the patient truly has symptoms or not. So, really, no role for prophylactic revascularization. There's really also no role for TPN and conservative management. So, if you have an old, frail patient, they will not, TPN and conservative management, if you've adopted a palliative approach, might be reasonable, but it's really not gonna help them and prolong their longevity. There are some unsettled issues in this area. How many vessels do you have to treat, and do you do it endo versus open? So endo therapy was first reported in 1980 for the visceral vessels, and what we've learned is that primary stenting with balloon expandable stents, whether bare metal or covered stents, is really the optimal treatment. And we'll talk a little bit about whether that should be done by a percutaneous antegrade or a percutaneous retrograde, or an open retrograde approach, which can be done as well. But the great majority are percutaneous antegrade. If you look here, this is from a study from the Mayo Clinic looking at endo and open revascularization over about 20 years, from 1990 to about 2010. And the black bars are open revascularization, the white bars are endo revascularization, and you can see that, the shift in therapy, particularly in the last decade, to where now endo revascularization greatly sort of dominates over open revascularization in terms of proportion of cases performed. So a little bit about the technique. There's really, I think, maybe a couple salient points. One very important point is about the access. Where do you go from the femoral or the brachial? And I think many people, and I know I myself judge it based on the angle of acuity from the aorta. So here in this case, you see this high-grade celiac artery stenosis, but you see that it comes off at about 90 degrees to the aorta. That's something that's actually fairly amenable to a femoral approach, because you can ask the wires, the sheaths, and ultimately the stents and the balloons to sort of traverse that angle without too much difficulty. So the base, really you can treat these, from a technical standpoint, you can treat these either through a guide cath, or many people would treat that with a true sheath, and then selection via the sheath, and then treatment from there. What I prefer is sort of a what many people call a no-touch technique, where you have a guide cath, you have a formed guide cath, you select one time with an 014 wire, and through that guide cath system, you immediately go to a pre-dilatation balloon, followed by some stent placement, some balloon expandable stent placement, whether bare metal or self-expanding. And what you want to achieve is about 2 millimeters. You obviously want to cover the lesion, but you want to have about 2 millimeters of this stent hanging into the aorta. So most mesenteric disease is orificial disease, so it's essentially aortic spillover disease into the ostia of the vessel. So you have to make sure that the stent actually is flared into the aortic lumen by a couple of millimeters. The technical endpoints, you should, if you have less than 30% residual stenosis or less than 10 millimeters of gradient across your lesion on completion, then you've achieved a successful technical result. And then most people, akin to lower extremity revascularization, treat with aspirin lifelong and Plavix for some period of time, and I think practice there varies. There's not a lot of hard evidence on that. On the other hand, if you have an angle that's a very downgoing angle, so you see here, I believe this was a lesion, like an intrinsic celiac lesion that was remnant after a median arcuate ligament release. And you can see there's a very downgoing angle of the celiac relative to the aorta. I think many people think that's best approached from a brachial, because you come down and you have a very nice gentle angle coming from above that allows for pretty easy passage of your stents and balloons. So in this scenario, you see that a guide cath comes from above, and then you can treat via a brachial approach. I think in this instance, or in almost all instances, having a pre-procedure CTA really helps you, because it's really, you want to know going into the case whether you expect to come from the arm or not. It's sort of painful to start in the leg, find the angles to be sort of troublesome, and then end up coming from the arm. So a pre-procedure CTA, if you can do it, is very helpful. So what kind of lesions can be treated endo? Well, again, it's very similar to lower extremity decision-making. Favorable endovascular lesions are short. They have minimal or moderate calcification or thrombus. And they can be chronic total occlusions as long as you have a little lead point to get into the ostia of the vessel. If it's a flush occlusion, flush with the aorta, and I'll show you a case here, that's very difficult, I think, to sort of get a good result with an endo approach. So unfavorable lesions for endo are the opposite of all of those things. So if you look at what are the results of endovascular therapy for visceral occlusive disease, there's been a reasonable number of studies reported over about the last 20 years. And the bottom line is that technical success is high. As you might imagine, mortality is low, although it's still in the 2 to 3% range, so it's not zero. And the patency tends to vary quite a bit. So primary patency about 1 year is reported between 40 and 80% for the most part. So the durability of this treatment is still suspect, I think is fair to say. What we do see, so this is a study from the Cleveland Clinic group, is that out to 1 year with they have primary patency of 65%. But with close duplex follow-up and secondary interventions, usually just angioplasty of in-stent stenosis or extension of stents sort of for edge of stent stenosis, you can really achieve very good assisted primary and secondary patency. There is a little bit about in-stent restenosis and what's the best approach to that. And I think ultimately, it can be pretty easily dealt with from an endovascular standpoint. And most studies have shown that in that case, if you go to a covered stent, that's probably the best treatment of in-stent stenosis of an original bare metal stent. So what about this kind of situation? So you do an aortogram, you see no visceral vessels, flush occlusions of the celiac and SMA. Well, then you definitely need to start thinking about your open options. And one point angiographically is, you can see here, you have to really you're not going to see these vessels light up in the initial sort of, your initial arteriogram. You need to wait for some delayed filling and reconstitution of the distal vessels to identify your target for a bypass, or have identified them on a CTA. So here you see on a late filling of the reconstitution of a SMA, fairly far out from the aorta. So we'll talk a little bit about open approaches now. So open revascularization, the gold standard for open revasc of the celiac and SMA is an antegrade aortoceliac or aorto-SMA bypass. And most commonly, this is done by a midline or a transverse abdominal incision. Usually the optimal inflow is the supraceliac aorta. So even in patients who have really calcific visceral disease, that distal thoracic aorta that you can access through the gastrohepatic ligament, divide the crus, will often be free of disease, be very clampable, and a acceptable site for inflow. And many people then will take a sort of a bifurcated graft. You'll have a short graft to the trifurcation of the celiac artery, and then generally a retropancreatic tunnel down to the proximal portion of the SMA or the mid portion where it reconstitutes. So usually a 12/7 bifurcated graft or a 12/6 might be a good option. And this just shows that the exposure of the distal thoracic aorta through the gastrohepatic ligament, having divided the right crus of the diaphragm. Now, if the patient is either too frail or too high risk from a cardiovascular standpoint, or has a really calcified, unclampable distal thoracic aorta, that's when you start thinking about retrograde bypasses. So shown here is an ilio-SMA bypass, and you can do these. You can take these bypasses out fairly distal in the SMA, actually. So in cases where the reconstitution is way out the SMA, and that's your only target, this is often a good option. And here's an example. It's one intra-op. So what you see there is this is actually coming off of the left common iliac artery, and essentially you end up sewing this bypass on the sort of the infralateral portion of the SMA. By the time you divide the ligament of Treitz, reflect the bowel up to the over to the right and upward a touch, you come down on the SMA almost on its underside. So when you create this bypass, you sort of have to picture the way that when the guts fall back, you're going to have a nice gentle C loop in the bypass that won't kink. So also you can see here on the reconstruction of this operation that we have kind of a nice C loop coming up from the iliac to the mid portion of the SMA. Most people for this kind of bypass will use a ringed PTFE for that reason. It sort of helps maintain that shape, whereas a non-ringed PTFE or sometimes a Dacron, if it's too redundant, might have a tendency to sharply kink in the middle of the bypass. So here's a sort of a separate entity. A certain percentage of patients will have what's called coral reef syndrome, and that's where they have dense atherosclerotic plaque at the origin of the celiac and the SMA. So if you look at that CT scan on the left, that's not contrast there that you see in the anterior aorta. That's a dense calcific plaque, and you can see on that sagittal view that's what you have there blocking the ostia. This is a disease more common in women. And it's a very interesting pattern of disease. Much of the aorta will actually be spared, so it's a little unclear why this develops right at that site. But this can be treated with aortic endarterectomy, and the approach to this is really, one approach is a total medial visceral rotation. So either through a midline or probably more commonly through transverse upper abdominal incision, all of the viscera can be reflected left to right to come down onto the aorta and the origins of the vessels, sort of like this. Another approach would be sort of a thoraco-retroperitoneal approach, really. You could do that, or you could do that as well. And ultimately, what you end up with is this kind of situation where you have these obstructive plaques at the origin of the vessels, and it's, after clamping, it's treated with basically either a longitudinal or a trapdoor-shaped aortotomy. Then allows you to perform a eversion endarterectomy from the origin of the vessels, and often you can get a whole single plaque out like shown there, that specimen in the lower right, and that's a very effective treatment for coral reef syndrome, where the atherosclerosis is really limited to the ostia. Am I over by a minute there? Over by one? Okay. Endo versus open revasc. Bottom line is there's no level 1 data. And really, the existing literature is basically fairly uncontrolled series with a lot of selection bias, as you might guess. So the bottom line is, in terms of open versus endovascular therapy, I'm going to just we'll go to the end here. What we know about that is that, really there's much less morbidity and mortality with endovascular therapy, but limited durability. And open therapy, on the other hand, has high rates of morbidity in the 20 to 40% range, relatively high mortality in about the 10% range in some series, but better durability of the revascularization. There are definitely some unsettled issues in this field. It's not really clear if endovascular therapy burns bridges for open therapy, but you can imagine it would if you end up extending your stenting well out the SMA into your areas of surgical targets. And it's still, we really don't know the exact best endovascular therapy yet. I think we need some additional strategies on the endovascular side to improve the durability of the revascularizations. Thank you very much.